Presenters are Jennifer Connor, Associate Professor, Brooke Shield Laurent, Christine Hartford, Assistant Professor, Carl Abraham, and Rajnarayanan, sorry, I apologize, Rajnarayanan from New York Institute of Technology, College of Osteopathic Medicine at Arkansas State University. I want to make sure that the screen sharing has started. And you may begin when you're ready.
Dr. Connor, you'll have to change your slides, the screen. If you go up to display settings up top and a drop down of the triangle in the black screen. You're muted, Dr. Connor.
Okay, so hello everyone. Again, thank you for having us here today. Again, we wanted to share our experience with academic and community partnerships along the Arkansas Delta. As was mentioned, we do not have any disclosures at this time. So we are from the New York Institute of Technology, Osteopathic Medicine, College of Osteopathic Medicine. We have two campuses, one in the Long Island area and also the campus in Jonesboro. Again, both campuses are really set up to service our communities. And I would just make of note that both campuses were also the first osteopathic medicine established in the state of New York, and also the first osteopathic medicines established in the state of Arkansas. We are the community engagement arm. Still no presentation. Is that, you can't see this presentation? I'm sorry, I'm going to keep going. So we are the osteopathic medicine. We are the community engagement arm. We're the Delta Population Health Institute. Our goal is to really establish multi-sector collaborations to create equitable communities. And we do that through partnering with communities through our 4 pillars, which are education, research, policy, and community engagement. What's interesting about the way our Delta Population Health is set up is that we have 3 spheres of influence that we really try to work through. I'm sorry. Can you see the slides now? I'm sorry for the technical difficulty. But the public, we do that through, again, the 3 spheres of influence here: the clinical and community linkages, public and community health, and rural community and economic development. So I wanted
Dr.
to—
Connor, could you
Yes.
change your display settings? Just want to see if we can remove the notes. If you hit from beginning like you had it.
Yes, I did. And then my screen just goes to full screen. It's not letting me do anything.
And then display settings, do you see that on the top?
No, it's a full screen.
Oh, okay. All right.
It's okay. So you're not seeing my screen at all then?
Yeah, we can see your screen. You can hit from beginning. We can view it in that mode.
Okay. Again, this is, I'd like to turn it over now to Dr. Hartford. Again, it's not going to let me advance. Okay, so Dr. Hartford, if you would like to speak at this time.
Okay, excellent. You can advance to the next slide. I'm going to talk about the educational arm of our work, which we started last summer when we reached out to various school districts throughout the Delta to provide webinars for their staff. So the school administrators, nurses, and teachers. And we focused on the basics of COVID-19 and also considerations for reopening schools in a way that was safe for both faculty and staff, and really just helping them make sense of all of the information that was coming out from the CDC at the time. Next, we connected with our local Hispanic Community Center to join their virtual after-school program and provide COVID-19 education specifically for children. And then finally, in the fall, we reconnected with the schools, but here we were focused on parents. So we wanted to provide information that we thought parents would be specifically interested in. So we covered what we knew and know about COVID-19 in children, considerations for school, playing sports, and helping children cope during this difficult time. Next slide. We engage medical students in our work from the very beginning. So our medical students participated in the webinars with the schools. They gave portions of the presentation and answered questions from the audience. They developed some educational handouts about COVID-19 that were geared towards both parents and children, which we were able to use in our future work. We also had a team of very motivated students who produced videos about COVID-19 safety measures that were geared towards children. So they covered things like wearing your mask safely, social distancing, proper hand hygiene. And we were able to utilize those videos in our work with the after school program and also post them on our social media outlets, which you can see here. And then our NYT students were instrumental in our work with the after school program. So we were able to pair our students with the children one-on-one or in pairs so that they could really individualize the activity to the age of the child, which ranged from about 5 to 12. Next slide. In terms of our results, we were able to connect with 5 different school districts throughout the Delta to provide our webinar. And this was done by a team of 4 of our pediatricians on faculty in conjunction with 5 medical students. For the after school program, there were 15 children participating in the program at the time, and we were able to provide the activity for each one of them. And this was done by a team of 18 medical students and with 1 faculty member overseeing their work. And then as far as the webinars for parents, we had 1 faculty member who connected with individual schools on a smaller scale to provide 3 of those webinars. And then we conducted 1 larger webinar at the end, which you can see here, that was open to anyone. And for that activity, we had 3 faculty members participating from different subspecialties. So we had a pediatrician, an infectious disease doctor, and a family medicine doctor. So we were able to field a wide range of questions, and that was very helpful. And in the end, we were able to, we had 60 registrants for these webinars from various regions throughout the Delta. Next slide.
Okay, thank you, Dr. Hartford. Dr. Raj, would you like to speak about our research?
Absolutely. Thanks, Dr. Connor. One thing I would like to say is like during COVID-19, having experience going through some of the pandemic trainings before, and also like working on SARS and MERS in terms of drug discovery and research projects helped a lot. So one of the things that we would say is start early, start planning for it, look at the global events, look at the events in other states, because things, when it hit Arkansas, a lot of things were happening outward. Being New York Institute of Technology, we had information from New York that exactly how to deal with initial pandemic, and then like we were ready by the time we started. So around March, we started building or like I would say that improving the lab so that we can get our CLIA approval to do COVID testing in our laboratories. So what it required was to make a biosafety level 2 laboratory amendment. We did that. And then once that was going on, parallelly, we trained a cadre of faculty and students with experience doing RT-PCR, and also like, like students that can, on faculty that can check people in and then process, in fact, all the way from the swabs to the transportation to doing testing in our laboratories and analyzing those tests, right? So in addition to those things, what happened really was, I've never seen during a pandemic, things fall into place nicely. When you're prepared, things happen, right? So that thing, exactly what happened. And when we got the CLIA approval, we were able to do mass testing, first mass testing of our students and staff during the summer. And then we also had information that, like there are some of the genes that may go missing, for example, the sensitive ORF1ab gene in the RT-PCR. So we adopted early on a multi-targeted RT-PCR approach. So we were always looking for an S gene, a ORF1 gene, and the N gene, and so on. So what happens, it came handy during the variant. So we started the COVID variant surveillance, looking for those positive samples, looking for the missing S gene, as in the case of the B117, the variant was originally identified in UK. During the pandemic, our researchers were able to provide, looking at the cycle threshold value, the CT values of the PCR, on guidance on the viral load, so that the patients can be taken care of similarly. And also we are, because of the TPHI, the Delta Population Health Institute, we wanted to make sure not only the testing, but also like the faster rapid testing is available to the rural community. So we immediately launched a colorimetric molecular testing. That's one of our ongoing projects using RT loop technology. And also we started collaborating with Arkansas Biosciences Institute on a wastewater surveillance project. Next slide, please. And during all these things happening, we also wanted to engage our students, not only the students from the schools, but also the medical students and everyone in the community. So we started a massive 3D printing factory project where many schools had smaller 3D printers. So we had provided them with files and training so that they can start printing things that they can use to manage, all the way from, like testing of, like filtered mask, nose clips, ear masks, the savers, and then, like hands-free door openers and whatnot, including swabs in some cases. Next slide, please. And then in research end, because of the experience working with SARS, MERS, and other viruses, so we were looking at drug discovery projects in terms of looking at the known targets, looking at the SARS protease to see are there any known drugs so that we can teach those known drugs to kill these new bugs, right? So we were looking for those approaches. And also we were looking at mathematical modeling based on the information, global information coming out and what it means to rural Arkansas, case projections, and so on. Then some of our faculty started looking at the ACE2, the human host receptor, binding to SARS-CoV-2 proteins, and then also how it would be different in terms of variants. And also we were looking at, in fact, our dean, Dr. Spites, was interested in looking at outcomes of antibody therapy. So he started to collaborate with St. Bernard's regional hospitals to look at those as well. And then we were also looking at behavioral population health level modeling of approaches that we learned from, let's say, Ebola outbreak and previous SARS outbreak, like ring vaccination. Can it be modified so that hard zones can be immediately mitigated? The next slide, please. The other thing that we were dealing with during this COVID pandemic, in fact, all of us dealt with it, is infodemic, right? So misinformation was something that was spreading like wildfire, in fact, bigger than COVID. So some of our faculty joined together and started a physician education working group, and they started curating information coming out, both research paper, the preprints, and those in the media. So they went ahead and looked at it. So we had a panel looking at all the data, then developed talking points and also like key information to the physicians and stakeholders in our community. We pushed it along. And also this was helpful in Arkansas Department of Health COVID epidemiological studies as well. And we are also continually looking at state level, local level, national level, global COVID data, and trying to project what's going to happen with the rural Arkansas and make sure that we can mitigate things when the variants start spreading. Next slide, please. So what I'm going to say in this slide is about the funded collaborative projects that we have. So we have the public health dashboard in the context of what it means for rural communities, developed in collaboration with Arkansas Biosciences Institute. And it's a project funded by the Arkansas Biosciences Institute. And we started a COVID impact study. Dr. Laurent and Dr. Connor is heading the study, and they'll probably talk about this much more along the way. So essentially what this grant means is to look at the structural and systemic challenges that we face across the board in social determinants of health, that, as you can see here, in terms of communication, healthcare, food insecurity, transportation, every one of those things, whatever you do, these things are there to make sure that we can take care of it and make sure the response is seamless. And I would thank opportunity for presenting, and I'll hand it over to Dr. Connor to continue.
Yes, thank you. So in our policy domain, our COVID-19 response was that we worked with local community leaders to really produce webinars and town hall meetings. There was a lot of misinformation, and we really wanted to cover the basis of COVID-19 and really help municipal and community leaders break down the information. So we hosted 9 webinars across the Delta with more than 150 participants. We worked with like the Black Mayors Association, the Community Health Centers, and the Community Health Workers Association, really just trying to get the affinity groups the information that they need. We also had another project where a faculty member led a team of medical students in creating training modules for telemedicine innovation and adoption. So this was, again, working with our local FQHCs. We did 3 training modules that included the new policies around telemedicine that was put out by CMS, as well as clinic safety and patient engagement. We supplemented that video in partnership with the Community Health Workers Association that really just had testimonies about how telemedicine could be used with success. At NYT in Jonesboro, we have a first district congressional fellowship. So this is working with our federal office where we accept students on a yearly basis to work with our congressmen to try to figure out issues that are facing our constituency along the Delta. So our fellows were instrumental during the pandemic to really address the needs of the rural populations along the district. Also, members of our faculty took state leadership positions and really looking at health equity and resiliency and the rural aspects of COVID-19. So several of both the members sitting here on this panel, as well as our other faculties, took leadership's role in having the narrative and the conversation to drive policy change, both at the regional and state level. The results and lessons learned from that is that we realized that local leaders really needed help navigating all the information, and things like press releases and talking guides were needed. So we developed the community response toolkit. It's based on our 5 C's, and those are coordinate, communicate, correspond, compile, and convene. And we recently received funding from the Arkansas Community Foundation to conduct resiliency training and further our information with the Arkansas Black Mayors Association. And I'll just continue by letting Dr. Abraham talk about some of our community engagement work.
You're muted, Dr. Abraham.
Thank you so much, Dr. Connor, and thanks so much to APTR for letting us present today. I'll tell you a little bit about NYITCOM. We're a College of Osteopathic Medicine. That's sort of a campus within a campus on the Arkansas State University at Jonesboro campus. And we already had a very strong relationship with the university system in providing medical expertise before the pandemic hit. Almost immediately after the first cases were reported, we were asked to help with their international studies program, and there were several students who were returning from that area that the university needed guidance on quarantining and isolation. As the pandemic progressed, the university approached us to help with their own efforts that they had set up in order to deal with quarantined students and exposures, and the Arkansas Department of Health became a partner with us and the universities, asking us to do the actual contact tracing. So we ended up doing the contact tracing for 11 campuses across the states. This is a very diverse campus population, some of them in urban areas, some of them in very rural areas. More than 38,000 students, thousands of faculty and staff. Some of the campuses had associations with daycare centers, which presents their own special cases when it comes to exposures. So this was a very complex endeavor. Again, there was a team of faculty and staff that was put together to oversee this operation, and faculty served as experts. So as very complicated cases would come through the tracers, they would come to us and we would troubleshoot exactly what needed to be done for every case and contact. And next slide, please. So the university and we developed an online self-reporting system so that the faculty, staff, and students could go online and tell us that they had been exposed to someone that might have had COVID, or that they had been tested, that they were having symptoms that they're themselves, or that they had received a positive test. And we used a database management system that was very adept at changing if we needed to, and we had a crack IT team that as the pandemic changed, we were able to adapt the system to the pandemic. For example, early on, we collected data on exposure in endemic areas, and as that wasn't important anymore, we didn't need to collect that information. But as the CDC changed their quarantine guidelines, for example, back in the fall when they shortened the quarantine, or recently when they added the vaccine data, each time we were within 24 hours about able to change our database and collect the information in a way that not only took care of those who were being exposed or who had positive tests, but we were able to transmit that data quickly to the Department of Health. We established a virtual call center where persons, including medical students and graduate physicians and persons from the community, were able to field phone calls from people with questions, and to also call back those persons who had self-reported. And we were working under an agreement with the Department of Health so that we were actually sort of a partner with them and acting in as their voice. Next slide, please. Very early on in the pandemic, we provided education to the ASU community, and as the campuses were preparing for the return of their students for the fall semester, we really hit them hard with education, especially what was quarantine and isolation, why was it important, why was it important to decrease the number of infections as much as we could, and that their participation in that endeavor was extremely important. Next slide, please. And here is a screenshots of the self-reporting form. As you can see, I know this is a little bit small, but depending on why you were reporting, for example, if you had a positive test or if you just had symptoms, this reporting form sort of adapted to what your answers were, and there were drop downs that collected information that were only relevant to those situations. And on the back end of this, in the REDCap database, this would form a record, and those records were reviewed by contact tracers and case managers. And as we got faster and faster, we were actually contacting these people who had self-reported within 24 hours of them reporting. We were also feeding information to the Arkansas Department of Health extremely quickly. In other words, for example, if someone reported a positive test, they had the ability to take a picture of that report, upload it to the system, and that information was transmitted on a daily basis to the Department of Health, sometimes faster than the laboratories were reporting. So this was an extremely adept system. Next slide, please. So we were very fortunate to have this opportunity to serve the community. What we found out is that as an academic medical institution, we were really able to provide education to the community and set up a system of contact tracing that was extremely adept and easily transmitted information to the Department of Health. We quickly recognized outbreaks in Greek life, also in places within the community. We would hear about positive tests from 2 or 3 different people who had been at a fraternity party or even just living within a sorority within hours of each other. And we were able to make those associations. Medical students and all of those who are participating gained, I think, very important experience with working in public health, seeing what the direct impact of these endeavors were, and to talk to people as not as clinicians, but as contact tracers. And out of all of the incidences of self-report forms, which were about 7,600, we had 1,500 positive reports. And I wanted to mention that this activity was partially funded by the CARES Act for the state of Arkansas. And thank you very much.
And lastly, we have Dr. Laurent to share some of our work around COVID testing and vaccines.
Thanks, Dr. Connor. I'm going to dive right into talk about what we were able to do in our communities on the ground. NYTCOM received a USDA grant to purchase a mobile health unit, 40-foot unit fitted with 2 exam rooms and intake area, was launched in 2019. And it is also equipped to provide preventive services, telehealth services. It's also an opportunity for interprofessional education with our medical students and also with the Health Profession School for Arkansas State University, which we share the same campus, where we have nursing students and social work students, as well as residents, medical residents who are in their residency programs in the community. This is an opportunity for us to provide healthcare services and also gather information on a more granular level, more so than what is seen on the for public data that might be available. We facilitate community health and wellness plans. There are community members, after we build a partnership through providing these services, that they invite us to the table to talk about what does it mean to convene stakeholders, the community, to address the uproot factors that affect health outcomes within their community. But I'm going to speak specifically to the COVID-19 responses that we've had around testing and vaccination efforts. Next slide, please.
4-minute warning.
Thank you. So in terms of our COVID response, we were able to collect data again on our REDCap system and data management and reporting. We were able to establish some text messaging system alerts to participants about test results. We operated with a memorandum of agreement with the Arkansas Department of Health so that we were able to issue isolation and quarantine instructions for those who tested positive. We did have mass testing events in conjunction with community-based organizations such as food banks and faith-based organizations. They also were very instrumental for those who did not have connection through internet or access to emails. They were able to help us collect information through paper so that we'll make sure that we were to address that internet divide that is very prevalent in rural areas as well. We were able to provide services through our faculty, staff, and medical students, and did receive funding through the Arkansas Minority Health Commission, which was funding that we received through the CARES Act so that we would be able to do testing in these regions. Next slide, please. And the final part of what we're doing right now is coordinating mass events throughout the Delta and Arkansas, the state of Arkansas. We have a registry system. We're mapping gaps in vaccine distribution that we really are seeing nationally right now, but we're being intentional of focusing areas, rural areas where there is an internet divide, making sure that we remove as much of logistical and mechanical barriers as much as possible so that folks can get their vaccination. What's absolutely important is to make sure we're collaborating with community-based organizations organizations, faith-based organizations, and employers to increase participation and make sure that our communication is appropriate with the language, and make sure that those who are presenting information reflect the communities that we're serving, specifically in BIPOC communities and those who are migrant communities where English is not their primary language. And so we're able to provide this service through with faculty, staff, medical students, as well as local partners. And we also receive funding as well through the Arkansas Minority Health Commission. Next slide, please. So very quickly, results and lessons learned. We find that there is a high demand in these very low resource areas along the Delta. The logistics can be very complex, especially when we talk about the way that the vaccines are managed in terms of where they need to be stored and avoiding waste at all costs. We also have to address hesitancy in communities where there isn't trust with the medical community based on historical events. And so it's so important that we work with ambassadors of the community to inform them and to send information, again, in language that's appropriate and that is appropriate in terms of health literacy. And we work with local community health workers who basically know the ground and know the people and know the community as well as part of our teams in these mobile health outreaches.
We'll be wrapping up soon. I'll give it another 30 seconds.
Thank you. So in summary, we saw there were a benefit in the virtual platforms, but also we were mindful of the technical gap and divide, so we had to supplement that. We find that the academic community partnerships were crucial to responding to current public health, education, and economic crises. And we use all four domains, across all four domains, education, research, policy, and community engagement. We're able to comprehensively meet the needs of our stakeholders in our community. And at the same time, medical students gain real-time experience during the pandemic response. Thank you so much for your time.
Thank you, everyone.